Hi guys, today let us discuss about laryngeal framework surgeries. What are laryngeal framework surgeries? These are nothing but surgeries that are done on the thyroid cartilage to change the position and the tension of the vocal cord without touching the vocal cord. So, we are not going to touch the vocal cord, but we will change the position of the vocal cord by performing surgery on the thyroid cartilage. So, Ishiki et al. Classify this thyroplasties into 4 types: type 1, type 2, type 3 and type 4. So what is type 1? It is called medialization thyroplasty. Here we have 2 cords. First, one cord is normal. The other cord, there is unilateral vocal cord paralysis. So because of the palsy, one cord is in cadaveric position. So we will have a gap here, glottic gap at the center. Because of the escape of the air, the patient will have poor voice quality. For such patients, we have to medialize the cord. This is type 1 thyroplasty, also called medialization thyroplasty. What is type 2? It is called lateralization thyroplasty. Here we are having adductor spasmodic dysphonia. So here one cord is normal, the other cord is in midline. So we have to lateralize this cord. This is called lateralization thyroplasty. Type 3. Type 3 thyroplasty is called shortening thyroplasty. It is done in patients with puberphonia. What is puberphonia? That is nothing but a male with a female voice. A male with a female voice. What will happen in female voice? It is a very high pitched voice. So the cords are very tense. So we have to shorten the vocal cord or relax the vocal cord. We have to reduce the anteroposterior length. So we are going to shorten the vocal cord. So this is called relaxation thyroplasty. Okay. Type 4 is called lengthening thyroplasty. For whom it is done? It is done for androphonia. What is androphonia? A female with a male voice. So we have to get her a female voice. So we already discussed female voice is a high pitched voice. So we have to lengthen the vocal cord so as to increase the tension of the vocal cord. So this is called tensioning thyroplasty. So type 3 is shortening, done in puberphonia, that is male with female voice. So type 4 is lengthening, it is done in female with a male voice, that is androphonia. Okay, let us discuss one by one. So first we are going to discuss type 1 thyroplasty. This is also called approximation thyroplasty. Here we are going to medialize the vocal cord. Another important surgery is arytenoid adduction. When it is done, whenever apart from the vocal cord, when there is a increased posterior glottic gap. So we have to reduce this gap. For that we have to rotate this arytenoid cartilage. Okay, this is called arytenoid adduction. We can add this surgery along with type 1 thyroplasty. Okay. Now type 1 thyroplasty. Okay. So how it is done? Type 1 thyroplasty. So here we are going to create a window in the thyroid cartilage. So we will first expose the thyroid cartilage. We already discussed we are going to do surgery only in the thyroid cartilage. We are not going to touch the vocal cord. Okay. So we are creating a window in the thyroid cartilage and an implant is placed on the thyroid cartilage to push the vocal cords inside. We will discuss it in detail. So important indication we already discussed, it is unilateral vocal cord palsy. One important contraindication is for doing a type 1 thyroplasty, this opposite cord should be functioning normally because we are going to medialize this cord. So it will come in midline. Okay. If opposite cord is not abducting properly, both the cords will be in midline. So what will happen? Patient will have stridor. To avoid that, always make sure that the contralateral cord is working properly. Okay. Another important point is, after any trauma, give 1 full year for the patient for spontaneous recovery before planning thyroplasty. So any trauma or any palsy, we have to wait for 1 year before we are planning for any procedure. Okay. So how is type 1 thyroplasty is done? First we will put a skin incision and expose the thyroid cartilage, and we will create a window. How is this window is created? It has measurements. So first we will identify the midline, and exactly at the midpoint is where the vocal cords will get attached to the thyroid cartilage. So 5 mm from the midline, a window is created which measures about 10 cross 5 mm or 12 cross 7 mm. After creating a window, this is the thyroid cartilage and this is the window. After creating a window, an implant is placed in the window. This will push the vocal cords medially. So this is the concept of type 1 thyroplasty. Okay, you are putting an implant and that will push the cords medially. Okay, so one important step is we should not breach the inner perichondrium of the thyroid cartilage. Any cartilage will have an outer perichondrium. This is the cartilage, inner perichondrium. So while creating a window, we will remove only this two and we will not touch the inner perichondrium. Why? Because inner perichondrium is rich in blood supply, so there will be chance of high bleeding, and also this implant may go and fall inside the larynx once you breach the inner perichondrium. So to avoid that, never touch the inner perichondrium. So what are the implants that is used? We can use a Thyroplasty implant, a Montgomery implant, a titanium implant or Gore-Tex. So each and everything has its own advantage and disadvantage, and you can see it later. Okay. Now these are some of the disadvantages of thyroplasty, type 1 thyroplasty. You can see it. Now I already discussed what is arytenoid adduction. To reduce the posterior glottic gap, you have to reduce it. So how it is done? First, this is the thyroid cartilage. This is the arytenoid cartilage. So we are going to put two sutures on the arytenoid cartilage so that we can rotate this cartilage medially. So how it is done? First we will trace the muscle which encounter is inferior constrictor. You cut the inferior constrictor. Next muscle we undergo is posterior cricoarytenoid. Trace the posterior cricoarytenoid. It goes and gets attached to the muscular process of arytenoid. Once you visualize the muscular process of arytenoid, this is the cricoid cartilage, this is the thyroid, this is the arytenoid. So once you trace the muscular process, you dislocate the cricoarytenoid and the cricothyroid joints. Okay, you should dislocate the cricoarytenoid and cricothyroid joints. So after doing that, you place two sutures on the arytenoid cartilage with the thyroid cartilage. Okay, this is arytenoid, this is thyroid. So this is the measurement. One suture is placed at the junction of anterior one third and posterior two third. Another suture is made at the junction of anterior half and the posterior half. So two sutures on the thyroid cartilage to the arytenoid cartilage. What will happen? This vocal process will come medially. This muscular process will go laterally. Hence the arytenoid cartilage will get tilted, and hence this posterior glottic gap will be reduced. Okay, this is arytenoid adduction. Okay, this is the end of type 1 thyroplasty. Okay, now let us go for type 2 thyroplasty. What is type 2 thyroplasty? We already discussed it is lateralization thyroplasty. So we are going to lateralize the vocal cord. Okay, this is done in adductor spasmodic dysphonia. It has two approaches, lateral approach and the midline approach. So how it is done? Type 2A thyroplasty, that is lateral approach. This is very easy. Just you expose the, explaining is easy but doing the procedure is difficult. So we will trace the thyroid cartilage at the junction of anterior one third and the middle one third. You make two incisions. Okay. What is the aim of type 2 thyroplasty? We should lengthen the vocal cord. Okay. So you make two incisions in the thyroid cartilage, and this is the posterior part of the thyroid cartilage. You have to pull this thyroid cartilage laterally. Okay. You put two incisions on the thyroid cartilage and you pull the posterior part of the thyroid cartilage laterally. Once you pull it, so it will relax. This will release the tension on the vocal cords. So important muscle involved in adductor spasmodic dysphonia is thyroarytenoid muscle. So by pulling the thyroid cartilage laterally, it will release the tension on the thyroarytenoid muscle. This will lead to relaxation of the vocal cords. Okay, this is type 2A, that is lateral approach. Second one is type 2B or the midline approach. This is similar. But here we are going to put incision on the thyroid cartilage at the midline. Okay, midline incision is made, and the thyroid cartilage is pulled laterally. Okay, this will again cause relaxation or lateralization. Okay, lateralization, relaxation as well as lateralization of the vocal cord. So this is type 2B or midline approach. Now going to type 3, that is shortening. This is again having a lateral approach and anterior approach, and this is mainly done in puberphonia, that is mutational voice disorder, puberphonia. Okay, how it is done? Type 3. Here again lateral approach. Here we are going to make incision on the thyroid cartilage, but unlike the type 2, after making an incision, a part of the cartilage is removed. Okay, a cartilage strip is removed from the thyroid cartilage, and the remaining part is fixed with the mini plate. Okay, this cartilage is removed, and the remaining part is fixed with the mini plate. What will happen? This vocal cord distance, anterior-posterior distance will reduce, hence it will shorten. Okay, the distance will reduce and the vocal cords will become shortened. So this is called type 3 thyroplasty or the shortening thyroplasty. Now coming to type 3B, that is anterior commissure retrusion approach. Here similar to type 3A, we are making an incision at the midline. Okay, and the part of the thyroid cartilage with the anterior commissure is pushed posteriorly. When you push the cartilage posteriorly, what happens? This cords will become shortened. Okay, this is type 3B. Now coming to last thyroplasty, that is type 4 thyroplasty, tensioning thyroplasty. We already discussed this is done in androphonia, female with a male voice. How it is done? Type 4A, type 4B and type 4C. It has 3 approaches. First is type 4A. This is called cricothyroid approximation. This is the cricoid cartilage, this is the thyroid cartilage. This is the vocal cord. Okay, we already know the important tensor of the vocal cord is cricothyroid muscle. Okay, by suturing the cricoid cartilage with the thyroid cartilage, we'll make 2 sutures on the right and 2 sutures on the left. Okay, 2 sutures on the right, 2 sutures on the left, and approximate the cricoid and the thyroid cartilage. What will happen when the cricoid and the thyroid cartilage is approximated? This cricothyroid muscle. This is the cricothyroid muscle. This cricothyroid muscle will get approximated. Okay, cricothyroid muscle will get approximated, leading to lengthening of the vocal cord. Okay, only when this muscle contracts, vocal cord will become tensed or more length. Length of the vocal cord will increase or tension of the vocal cord will increase. So this is our aim. We have to get a female voice for our patient. Okay, so we have to increase the tension. This is done by cricothyroid approximation. Okay, what is type 4B? This is lateral approach. How it is done? Similar to type 3, we are making 2 incisions on the thyroid cartilage, but here we are placing an implant. In type 3, what we did? We removed a piece of cartilage. Here we are going to place an implant. Okay, sialistic implant is placed in the thyroid cartilage. This will lead to increase in the length of the vocal cord or increase the tension of the vocal cord. Okay. Now the last approach is type 4C, that is anterior commissure approach. So what happened here in type 3? What we did? In type 3 what we did? This anterior commissure was pushed posteriorly, but here this part of the thyroid cartilage along with this anterior commissure is pushed anteriorly. It is moved forward so that we can increase the length of the vocal cord. Okay, this is just opposite to type 3 thyroplasty. Type 3, this anterior commissure was pushed posteriorly. Here it is pulled anteriorly. Okay, this will lead to increase in the length of the vocal cord. Hence, once the length increases, the pitch will increase. Okay, thank you so much.